Good morning, everyone. I would like to thank you for joining us on this Friday morning. Just a couple reminders. Please remember that when you submit questions, to submit those to all panelists. That way, all of our presenters have an opportunity to see that question that has came in, and we can address that accordingly. The second piece is, I know that sometimes I get messages and people say, oh my goodness, am I the only one on here? No, I promise you're not. Right now we have 232 folks, and there are others still rolling in, so you are not on here alone. We do have a really nice turnout today. So with that, I will go ahead and turn it over to Dr. Stanislaus.
Everybody, one of the things I want to talk about today is the third dose recommendation by CDC and Department of Health and Senior Services. There is a document which we will talk about who are the individuals who are eligible to get the third shot. So this is the information that came out on August 17th from the Department of Health and Senior Services. And I know there are a lot of questions regarding who are the ones who would be eligible to get the third dose. Give me one moment while I pull up the document on my end as well. So this is the recommendation for who's going to get it. One is that if you have a medical condition or a combination of an immunosuppressive medication or treatment, but it also says not including. So these are some of the things that I'm going to go through in order, but not including, meaning that in addition to this that I'm going to talk about, if there are other conditions that the doctor, the physician believes would meet criteria for them to give the third dose, then they would. A little bit of background as to why CDC and FDA have recommended a third dose is because there is some studies that have shown that the effect, two studies have shown, number one, some individuals with immunocompromised conditions, such as those who have had transplant or are taking medication that suppress their immunity, they do not mount the same amount of antibody response that a person without those conditions does. So how do they know that? They have tested the antibody level. So basically when they give the shot in the arm, the body produces, in response to that shot, antibodies in the body that will protect the body against the viral invasion, or even if it invades, it will fight it. So that is the antibodies. The antibodies are those that are produced by the body to fight the virus. So this antibody production is very important after vaccination, because that is how you protect your body from the ill effects of the virus, which can cause pretty serious side effects, which can cause pretty serious illness. So this protects it. It's like it's really important that the body produces the antibodies. So research has shown that individuals with immunocompromised conditions their bodies did not produce the same amount of antibodies that a healthy individual's body produced. So there was one reason they thought, well, those who have immunocompromised conditions should get a third dose. Another reason is that they have found that, especially with Pfizer, that as the period went on, for example, when they were in month 1, there was a little decrease in the antibody level. Month 2, there was even a slight decrease, a few percentage points antibody decrease, and then as it went on to month 3, it dropped even further. So for month 1, it was 90% for Pfizer, month 2 was 85%, and then month 3 was 78%. So there's about a few percentage points drop in the antibody level with Pfizer. So based on these two information, CDC and the FDA have come up and recommended that they give a dose or the third dose of the vaccine. So let's look at what conditions they are. And I'm going to go through them, and they're on the screen. Number one is those who have immunocompromised due to a solid organ transplant. What does that mean? Like a kidney transplant, a liver transplant, that is a solid organ transplant. And anytime you have a kidney transplant or a liver transplant, individuals are prescribed immunosuppressive medication so that the body does not reject the organ. The number two is if somebody's getting treatment for a tumor, a solid tumor, or have blood cancer, such as leukemia or any other kind of blood cancers. The third one is if somebody has received a CAR T cell or some kind of a stem cell transplant as a treatment for their medical condition. Number four is if they have a primary immunodeficiency condition, and these are some examples of it. That means the doctors have told them that they are not, their body, it does not produce a normal immunoresponse. If individuals already know for whatever reason they just don't mount the same immunoresponse. So there are some medical conditions. The next one is if someone has advanced or untreated HIV infection. Untreated is the word, untreated HIV infection. And there are the next one is when you have active treatment with high dose corticosteroids, and there may be immunocompromised conditions that may need high dose corticosteroids, or a lot of autoimmune diseases where the treatment is with corticosteroids, or there are other medications such as Humira or any of those other medications that suppress an immune response. Yes, rheumatoid arthritis is considered one of those kind of medical conditions, and you are on high. Usually, the treatment of rheumatoid arthritis could be you are on a high dose of corticosteroids or on an immune suppressing medication, or any other medications to change the immunity or suppress the immunity or modulate the immunity. Then those individuals will also qualify. Okay, so it's very technical, the language in here, but basically, if you have an autoimmune condition, example is rheumatoid arthritis, ankylosing spondylosis. There are several of these autoimmune conditions, Crohn's disease, ulcerative colitis. There's several of them, and if you suffer from any of these conditions, or the individual you are caring for, in your care, maybe an individual with intellectual disability who's under your care, and they have these medical conditions, they all qualify for the third dose. Okay. Now, again, the key word is not limited to. So let's say the physician believes that you have it doesn't fall into all these categories, but still have something they believe that you may be moderately or severely immunocompromised, then the doctor can decide and recommend a third dose. Now, if you're an individual living in the community, and how can you go get the third dose? Pretty much at this time, all the places, CVS pharmacy, Walgreens pharmacy, or even your doctor's offices, any of the places that are capable or able to provide the vaccination, the first and second dose, can also give the third dose. So what do? You just call them and say, hey, I need a third dose. And many of them, I think I heard from somebody yesterday, they said they just called CVS pharmacy, and basically the person said, are you in for your first dose, second dose, or third dose? So it was that simple. So you can just go in there, and there is a self-attestation form where you just self-attest, saying that you do have an immunocompromised condition, or the person you're taking in has an immunocompromised condition. It's a self-attestation. You don't need any evidence, no documentation, nothing is needed. You just say that you have the condition, and they will allow you to get the third dose. So when should you get the third dose? The third dose should occur at least 28 days should be between your second dose and your third dose. Okay, so at least 28 days. So if you've had your second dose in less than 2 weeks, then you want to wait another 2 weeks. So, but if it's any time more than 28 days, it could be 2 months, 3 months, it doesn't matter. but it is at least 28 days before your before you after your 2 doses. So before you can get your 3rd dose. And what can you get? Like, for example, if you had 2 doses of Pfizer, you can get your 3rd dose of Pfizer. If you got 2 doses of Moderna, you can get your 3rd dose of Moderna. The only thing is J&J has not spoken about what needs to be, whether they are going to come up with a booster dose or not. We do not know that. So right now, those individuals who have had the J&J vaccine at this point, there is no recommendation to get another dose of J&J vaccine. And they actually discourage individuals to mix different, it's not given. Now, there is a statement though in this particular document that you're looking at, where it says that if the mRNA vaccine product given for the first 2 doses is not available or is unknown, either mRNA 19 product can be given. Okay. So, so for example, if you get Pfizer or you didn't know what they got, you didn't know what you got, whether it was Pfizer or Moderna, either Pfizer or Moderna you can get, or if it is not available in your place, like you got Pfizer, but the Pfizer was not available, they can give you a dose of Moderna, but it's preferred you get the same dose. It's preferred that you get the same vaccine as your 3rd dose. Somebody raised a good question about J&J. Can we get another, just go get Pfizer, 2 doses of Pfizer? The CDC has not provided any recommendation at this point, but I would say talk to your doctor, because there are some studies that have shown that mixing the vaccines has helped produce better antibody response. There are some scientific data out there, but the CDC has not recommended anything. So what I would recommend is you talk to your doctor or the physician. If you're taking care of somebody, individual with intellectual disability, then that's a conversation to be had with the physician caring for the individual. Because at the present time, CDC and the Department of Health and Senior Services is not recommending that. Any questions? I'll be glad to take questions. Let me open up the chat. Heike, can you read those questions or the chat questions so we can answer?
Absolutely. We have someone said, if a person, and you may have touched on some of these a bit, but I don't want to miss any. If a person is immunocompromised but not in the categories listed, do they need written prescription to get the 3rd dose?
No, basically you can walk into any place that gives vaccination currently, sign the self-attestation form. Basically you're saying you have a condition, you meet the criteria, or you just self-attest and they give it to you. So you don't need a doctor's letter or anything from the doctor.
Okay, and then we have, are you recommending that everyone gets a booster 8 months after their 2nd shot?
At this time, that has not come out of CDC or Department of Health and Senior Services. It is in the works. They are talking about it. I think the organization ACIP, which is the organization that makes recommendation on immunization protocol, they are meeting sometime, I think it's August 25th. And if that passes, then I think by September 20th, individuals may be eligible to get the 3rd dose just automatically after 8 months of the 1st dose. So at this point, that has not been promoted or that has not been given in writing by CDC or the Department of Health and Senior Services, but that is in the works. Once we have a final decision and a recommendation by CDC, then we can do it. But until then, just hold till September 20th for that.
We have, since it is suggested that immunocompromised individuals receive a 3rd dose, does the efficacy of the vaccine decrease every month? And will those individuals need to get a 4th booster?
We don't know that answer. I wish we knew, because this is again a new virus. We don't know much about it. We are learning as everybody's experiencing it. The scientific community is learning about it. So it would be great for people. We hope for the best when we give the vaccine and say how long it lasts. But and again, there are two different things to remember. That is the lab data, meaning they take somebody's blood or serum after they have been immunized, and then they test it against these little viruses and see how much neutralization occurs in the lab. That is one kind of scientific data. And then the other kind of the data is observation in real life data. What happens to individuals who come out in the community with all kinds of medical conditions? How does it work? So sometimes there's a discrepancy between the lab data and the community data. And the community data, we can only really have an understanding of community data unless, when it is in the community for 6 months or longer. So it is something that is monitored closely and will be studied closely. So at this point, we do not know. It may or may not. So we just have to wait to get more guidance on that. But there is definitely some indication, at least with Pfizer, that there is a decline, maybe a few percentage points. It's not a lot. It's like 5% decline after several months. Again, it may not be for everybody. Again, but there is a decline.
Okay, someone asked, is the booster different than just getting a third shot? Why do they call it a booster?
They should not be calling it a booster. It's a third shot. It's basically, when you think about it, it just boosts the immunity that the body is already produced in response to the first two. The first two had some response, but is not enough in the immunocompromised individuals. The third dose will go in and boost that immunity. That's why they call it the booster. But I see it as both an interchangeable. You could call it the booster or the third dose.
Okay, and I think that addresses pretty much the next question that came in. That is, does the vaccination booster have more effects toward the variants?
It actually, the more antibodies you have in your system, it can fight the variants. Is it a 100% match to the variant? We do not know. What we do know is that even though individuals are still testing positive, who are vaccinated are testing positive for COVID, they are not, even the Delta, they are not ending up in the hospital beds as much. The rate of individuals hospitalized and dying from COVID in vaccinated numbers are much, much lower. Significantly lower. I would say less than, I think 98% of those who are in the hospital or on ICU beds are unvaccinated. So it does protect the individual from getting seriously ill and ending in the hospital and death. But when it comes to real protection, is it 100% match for Delta? At this point, all we know is it gives protection and it stops you from becoming seriously ill.
Okay, next question is, has there been a study on the booster shot to determine the side effects?
It's exactly the same dose. So it is like, if you go, I think it was I don't remember now exactly, but it is 0.3 ml for Moderna and 0.5 ml for Pfizer, I think, or it could be the other way around. It's the same vial, it's the same dosage. Everything is ditto, everything is same. What studies we have is when given the third dose, especially the studies that come up in individuals with immunocompromised conditions, especially those who had renal transplant individuals, they found that when they did get the third dose, their body was able to produce more antibodies and keep it sustainably higher. Just kept the level up, especially in transplant individuals. So that was the reason behind this current recommendation from CDC. So it is the same, ditto the same thing. So if you did okay for the first two, you should be okay for the third one as well. Again, do we have long-term data? I mean, how much longer these antibodies are going to last after the third dose? We don't know that information. We just have to, really have to rely on science, and we have to give that time so that the science is accurate.
Okay, Someone asked, if you had COVID, let's see, if you had COVID, both doses of the vaccine, would it be necessary to get a booster or third shot? Is your system protected more because you've had both of these things?
Okay. So what we are finding is that individuals with COVID, again, their antibodies have dropped even more drastically than that from the vaccination, because the vaccination produces several-fold more antibodies than the COVID infection itself produced, especially those who had asymptomatic or mild COVID infection the first time around. We are finding a lot of reinfection. So that is not protecting the individuals right now. So if you already had a COVID infection, let's say you had COVID in last year in 2020, and then you had vaccinated, then that helps increase the immunity a little bit more, both together, and then taking the third dose will help it even further.
All right, I think that is all the questions we have at the moment.
So, the reason yeah, go ahead. Anybody have a question?
I think we're good.
All right. So it's important that, individuals that are in the care, intellectual disability individuals in the care of community providers, that you particularly take a look at conditions that they have and if they may qualify for the third dose. And if they do, please do make sure that they get them. The important thing to remember with vaccination is that for most of the individuals with intellectual disability, they don't make the decision for themselves. They have a caregiver or a guardian who makes a decision. So it's very important that we provide the information the guardian needs so that they can make an informed decision when it comes to vaccination. As I said earlier, I don't know if anybody had heard me say this, the amount of people, those with intellectual disability are dying at a much higher rate from COVID and having more complications from COVID than those without intellectual disabilities. There was a huge study done in England, and they came up that having intellectual disability is itself a risk factor to have a negative outcome from COVID. And we know that, the number of individuals with intellectual disability, who have not been vaccinated is very high. And I can tell you in the last, I was just looking at the data in the last month, and I've seen, at least the last 2 to 3 weeks, and I had seen 4 individuals who had passed away with intellectual disability who had passed away, and all 4 of them were unvaccinated and under the age of 35. So it's really hitting really young people and who are unvaccinated. So this is really a wake-up call for the intellectual disability community to see what can we do to prevent deaths among our residents. And the other thing is also, if I live in a home, I have control over who comes inside my home, how I can protect myself, and what I can do. Unfortunately, those with intellectual disability are at the mercy of the staff. So they are, if there is more community transmission going on, staff live in the community and they can easily transmit within the homes. So they have really no protection. The third thing is many of those with intellectual disability, at least if they're on a moderate intellectual disability or harder, many of them cannot wear a mask because it's not safe for them to wear a mask. Higher functioning, those with intellectual disability, of course, they can wear a mask, and those who are working, who are able to function higher, are able to wear a mask, but without them, they don't. So, there's so many mitigation strategies that we cannot use for intellectual disability. So vaccination really makes a huge difference for this population, and staff getting vaccinated makes a huge difference because that way they are protecting the resident as well. And masking, I cannot stress the importance of masking in the group homes. Just if you mask, that you're less likely to get anything that virus only comes out of a person from their nose and mouth. If you mask it, there's no way it's going to get out. So it's very important that people mask, especially staff who work with intellectual disabilities. And vaccination, I cannot stress the importance of that. Any other comments or questions from the chat, Kaika?
One other one, is DMH going to provide the opportunity for us to get the third vaccination here at the office if we want it? I'm asking as it would help us ensure that we have received the same dosage we received last time.
Get in touch with me, let me know, and we can work through it. If you have, the thing is that DMH has ability to get them, our Department of Mental Health, DBH, a Department of Behavioral Health facilities like Fulton, State Hospital, St. Louis, Slip Lake, MPC, Farmington, Southeast Missouri Mental Health Center, the west side of the state, CBM, Northwest Psychiatric Rehabilitation Center, all are vaccinators. So they can provide the vaccination. So, but the offices are not. So the best thing would be that either if you send us how many vaccinations you need or how it could be arranged, we can find a way to get you vaccinated within the state system. Or I think vaccination is so much more available these days. You can just walk into a CVS pharmacy or any place and get vaccinated. So I think that'd be easier to do if you're working in an office versus a facility. But if you're working in a facility, get in touch with the administration in the facility. If you're in the office and you've tried other methods to get the third dose, you meet the criteria, and you've tried other ways like a pharmacy and you're having struggling to get it, send me an email. We'll figure it out. We'll help you out.
Okay, I do not think that there are any other questions that have came in at the moment.
All right, with this, then I will log off and let you continue with the rest of the agenda. Thank you all.
Thank you, Dr. Stanislaus.
Okay, thank you. This is Angie. I have a couple of updates to provide everyone. The first one is that we did receive partial approval of our spend plan for the enhanced 10% FMAP. An email blast and a posting will be going out from MoHealthNet soon, and then our division will also follow up with an email blast to make sure that everyone sees that. Now, the partial approval from CMS, that only qualifies Missouri to receive the temporary 10% increase of the enhanced federal match. It's not yet an approval for claiming any federal financial participation. So that's a lot of big words. That basically that means that they've approved for us to earn enhanced federal match, but we do not have approval to claim any federal match on items that we've included in our spend plan. CMS has additional questions for Missouri for all of our departments, Department of Mental Health, Health and Senior Services, and Social Services. And to get that full approval, including implementation of rate standardization and the rate increases, is conditioned upon us resolving those issues requested by CMS. And the three agencies, we're currently drafting responses to the CMS questions, and we're working to submit those as quickly as possible. Based on those outstanding items that we have, we're not expecting approval from CMS for at least another 30 days. So that does push back our anticipated timeline for the rate adjustments to probably late September, sometime in October, but we will definitely keep you posted on that. And I will say that CMS has scheduled a call for us to discuss the rate standardization and the spend plan the first week of September. So we believe that we'll have more information after that call. We understand how frustrating this is for you, for our providers, just as much as it is for us. So please know that we are continuing to work hard on this from our side, and then responding to CMS as their concerns as quickly as possible. So we will definitely keep you posted on how that moves forward. We also received approval on August 13th for our fifth Appendix K submission, and that was to add the new health assessment and coordination waiver service in all of our waivers. And that is to be effective July 1st, 2021. So we are working on guidance that we're going to send out to transition people from using the current StationMD service to the new waiver service. Basically, it's going to be the same service, but we're just able to draw down federal match for that, and it's part of our Appendix K waiver services, with the hopes that we can eventually put it in permanently to our waivers. So be looking forward to that guidance that will be coming out as well. And I think that is all the updates that I have today. So I'm going to pass it over to Wendy. I think she has a few more for everyone.
Good morning, everybody. Can you hear me, Angie?
Yep, I can.
Okay, thanks. I just wanted to go over the support coordination monitoring guidance that went out, and there's a few questions in the chat that I think that will relate to this. So you might also have to send some more information to me in the DD mail so that we can get more specific. But the support coordination monitoring guidance was not intended to change any monitoring schedule. So if you have someone on your caseload that gets an annual visit, they will still get an annual visit, and that annual visit needs to be face-to-face and they need to be seen. If they get quarterly visits and one of those visits has to be face-to-face, then you've got flexibility in there based on when they were seen last face-to-face. If it needs to be, this quarterly visit needs to be in person, or if they need to be seen face-to-face. It is really guidance for our residential services that require a monthly visit, a monthly face-to-face visit. When we put counties or notify that counties can observe a remote-only monitoring status, those services for 2 months in a row can be remote, can be virtual, but on that third visit, so you're not going more than 90 days without seeing a person face-to-face. So I hope that helps to clear up some of the confusion around the schedule of it. The intent is that no person that is supposed to be seen monthly will go more than 90 days without being seen in person. All the other schedules already allow for, there to be a year before they're seen, but in that year's time, you have to see them. So just know when you come up upon that year, even if your county is in a remote only status, but it's time for that annual visit, that needs to be in person if that is how the service is regularly monitored. Same with the quarterly, we have to see folks. The support coordination is a very critical and crucial service in ensuring that our folks maintain their well-being, health, and safety. And so being able to see people face-to-face still is very, very important and very critical. And there are ways that we can do it face-to-face in the open air, but still see someone in person and be completely safe in doing the monitoring. If you're seeing them through a patio door or a window or something of that nature, you are seeing them personally. You can lay eyes on them and you can somewhat see the environment, and then do a visual tour of the home to see the environment aside from that. So I hope that that helps to clear up some of the confusion around that guidance. Again, not intended to change your monitoring schedule. That doesn't change, just the allowance of it being remote and when it needs to be in person. No one should go more than 90 days. And that's why we didn't want to say quarterly, because if you went and saw someone the first month of a quarter and then the third month of the following quarter, you would have more than 90 days in that time span before you saw them again. So it's not one time quarterly, it's you have to see them once every 90 days. So if there's still questions or confusion around that, please put something in the chat or send it to the DD mail, and I will call you, or we'll work through that depending upon the confusion.
Hey, Wendy, there are a couple questions in the chat if you have time at some point before we're done. Just want you to know that they're there.
Okay, so clarifying, can we do in-person visits to waiver case management only quarterly if they fall in between now and September 30th? I think the question is, have you seen them? I'm going to do case management quarterly. If you're supposed to see them face-to-face quarterly, then the question is, have you seen them in the last 90 days? When you're due for your next quarterly visit, if you had not seen them in the past 90 days, then that visit needs to be virtual or needs to be in person. If each of your quarterly visits is supposed to be in person, then they need to be in person because that is 90 days. That's your max. But if it is a service that does not require a face-to-face meeting quarterly, then you have flexibility. Can I see them in person at their home, but then go back to the office and complete the annual ISP review paperwork with their team? Yes, you can do that. Once every 90 days, just for residential. Yes. Again, the quarterly monitoring visits, if those quarterly visits are each supposed to be in person, then they would need to be in person. If it's allowable for 3 of them to be over the phone and 1 a year to be in person, then you need to be sure that that 1 a year happens in person. You have the flexibility on those other quarterly visits. If services aren't active, I think it's even more important to see them. Do you agree, Wendy? Yes, absolutely. You know, that's why we don't want, if you're only seeing them annually, we don't want that visit to be a remote visit, a virtual visit. It needs to be, you need to see them. It needs to be in person. Absolutely agree. So for those services we need to see quarterly, do we need to go out and see them each quarter, even if we have seen someone since April 1st? Yes, this is updated guidance. So that first guidance where we talked about April 1st was to give guidance around just the time frame. I think we said through August or through September that we were going remote, and now we've extended the remote monitoring guidance, and so we've set a different parameter so that you can understand when you need to see someone in person versus not seeing them. So if you haven't seen them in over 90 days, you need to be seeing them. Case managers are just doing regular visits instead of open air. They are going into homes and day programs and not trying to do open air. Can you offer guidance around how to handle this? This, I think, you know, you need to work with your teams. We believe that visits can be done safely. It depends upon the circumstances of the folks in the programs and the staff that are visiting, the support coordinators that are visiting. We need to give each other grace so that everybody feels that they are doing what they need to do and being respectful of their concerns for spread. But if people are coming to a day program, then that would imply that there's already some comfort level with them being around other people. So it doesn't really strike me as a problem that a support coordinator would go in to the day program and do that visit because those folks are already agreeing to be out in the public and out in the community and going to that day program with other folks around. If you are going to a home or a group home, you need to work with that agency staff and determine what is the best way to do that visit. Again, you can see someone open air and be completely safe and meet the requirements for being in person. If you are concerned for the safety or well-being of one of the individuals in the home, if there's an allegation of abuse and neglect that you need to check on, if it is a provider or a house that you have had concerns about the safety of the home or the people in the home, then you need to go and you need to see those individuals. You need to first take that into account if you need to see them for the safety of the individual. That's why we can't make just a blanket statement that covers everybody all the time, because there's so many individual circumstances. And you know what those circumstances are. You know who you're concerned about. You know if there's a provider that's really struggling, or if they're really having a hard time with staff and you want to see if they've got staff in the home or PPE or whatever the case may be. You need to go see those people if you have those concerns. Always err on the side of safety and see people in person. Do the personal distancing, the social distancing, wear a mask, wear 2 masks if that makes you feel more comfortable and safer. If you need to go into the home, or if you can do your visit through an open window or through a patio door or something like that. Okay, there's jumping out. Heike, I might need you to help me keep track of where I'm at in the questions.
Sure. And a quick reminder, make sure you send those to all panelists. I know that I received several messages just to the host and also asking for my clarification. So make sure they come to all panelists. So Wendy, I don't think you have had, is the statement about going to see someone and just talking quickly outside to see them and completing paperwork, such as Appendix B, or reviewing progress notes and calling and having further conversation about satisfaction at the office, apply to non-residential services like PA, ISD, CN, et cetera?
Yes, you can do those activities remotely. It's your in-person monitoring visit that you need to abide by, and follow your schedule for it. And the other paperwork pieces that you would normally do while you're there on the visit can be done remotely.
What do we do about the day hab providers or other service providers not having the video technology to do open air monitorings and not allowing staff into the building?
You need to work with your TCM TAC and provider relations in order to resolve those issues. It's a requirement for all of our providers by now to have that remote technology available to them. So we'll need to work through that individually with those providers. So please reach out to your TCM TAC and your provider relations person in that region for more help with that.
Okay. With the positive apps for tracking visits, are SCs to submit for all visits, including telehealth and in person, or only when it is a telehealth visit?
If I'm understanding that question correctly, is that we were requiring support coordinators to record in apps if they were doing any sort of modified monitoring. So if you're doing the open air in-person visit, you would just note that you're doing that open air in-person visit. And why? If it's, that for safety, if there's positive staff in the home, or there's a positive client in the home, or there's exposure, or this is just the precaution that you're all taking. So, but if you're just doing your regular visit, you're going into the day program or whatever, then that would not need to be documented. And I did put that question out to Carrie Williams too, to look at that. So if she has any clarification to that question for you, we'll get that out to you all.
Okay, there are a couple, actually a handful of additional questions that have came in. I know we're about to hit that 11:15 mark, and we still have some other folks that have information to share. So I'll make sure we pull the report on this so that we can follow up with those questions. And then, Wendy, if there's anything else you wanted to touch on.
Yeah, no, I think that's a good idea. And just remember, this is no different than what we did the first time around. So however you dealt with the situations in providers or families not being comfortable with an in-person visit, it would be the same thing that you would do this time around. So we will go through and answer these questions. And if you have any more, please send them into the DD mail. That would be great.
Okay, and I think that brings us to StationMD, and Dr. Trivedi, I believe you are on with us?
Yeah, hi. Can you hear me all right?
Yes,
Okay,
we can.
great. Thanks. So I just wanted to give a little bit of update on what's going on, and then also just speak to some of the issues regarding COVID and what's going on. I know Dr. Stanislaus went through a pretty thorough overview, but from the perspective of StationMD and our services, um, first and foremost, I just want to let everyone know that our services are there. Don't want to sound like a broken record, but we are there as a resource. There's been some confusion about when to call and when not to call. The bottom line is call us if you have any questions about COVID, non-COVID, any medical concerns that you may have. What we're seeing right now in Missouri and also in other states, of course, is that our hospital systems are reaching capacity or at capacity or near capacity. Anything we can do to reduce the burden on the healthcare system, meaning if you don't really need to be in the doctor's office, urgent care, ER right now, please do all your best not to. And that's where we come in. If you need a med refill, you need an evaluation, you have a question about COVID, anything that's related to medical, StationMD is available. Again, the division has been fantastic about providing this service and also all the great work that Angie and her team have done is transitioning this to a waiver. But we are there, and I think it's imperative that we all let the individuals that we serve know that this service is available. In that vein, this week we will be sending out another mailer, which basically a postcard, which kind of talks about our services and has the 1877 number. But if you go to DMH's website, there's plenty of information. There's packets for families to kind of explain to you what the service is and if there's any questions. The other thing I will let you guys know is we had a town hall meeting on the 17th, and there's another one coming up today at 2 p.m. about really the vaccine and the importance of getting vaccinated, and just a general informational session. Dr. Stanislaus will be on, and Dr. Unadkat from StationMD will be on to kind of go over what's going on, a review of the latest from CDC, and there'll be an opportunity, I believe, to answer questions. We have also planned another Facebook Live event, which will let you guys know when that happens. Just want to reiterate that what we are seeing right now, especially in the community, those individuals that are living in residential settings that maybe are not part of a group home, they're really struggling with issues of their ongoing medical needs, whether it's COVID or not COVID. We want to make sure that people continue to get the care that they need, the refills that they need, the medical attention that's needed. And again, as you're probably reading about in the paper, know that hospitals are getting full, and unless it's a true emergency, and even in those instances, sometimes they're having trouble getting people to ICUs and transferring and being on diversion. So now more than ever, we're on this second kind of wave of COVID, and we want to let you know that this service is available, and please let everyone know that this service has not changed. It's there for anyone that's on the waiver, completely free of charge. So that's really it in terms of updates. I don't know if there's any questions in the chat or anything about that, but if not, I will turn it over to Jess. And again, we are there. If you have questions, you can also contact me, and the website has a lot of information as well. So thank you.
Thanks, Dr. Trivedi. I'm looking forward to the webinar and appreciate you putting that on next week. I think it'll be extremely helpful. So Just a couple of updates. I know we're getting into kind of the last few minutes here. So the questions that came in the chat regarding the updated monitoring guidance have led me to believe that it may not be crystal clear still. Captain Obvious statement. So Kim Stock had a great suggestion that she sent to me privately about creating a decision tree, perhaps even breaking some pieces of that memo off into an FAQ based on the questions that we've received here today, as well as those that come into the DD mail as we move forward, to make sure that it's just really clear to everyone when in-person monitoring is required. And again, in-person, open air is the same thing. In-person means seeing the person with your own eyes, not through a screen. And so that will be coming out, and we'll get that together as quickly as possible and look forward to your feedback on that. I hope that's helpful. Also coming soon will be some information regarding more vaccine education and what support coordinators can do to help families and individuals make decisions regarding vaccination. And that is also going to be including some information regarding some possible incentives. We're just looking at everything we can do to partner with UMKC, to partner with the DD Council on what is available to make sure that we're getting education out in the best way possible and providing you all with all of the resources that you need, whether it's a provider or a support coordinator or both, anyone involved in that person's life being able to have the information they need at their fingertips that's easily understandable, as well as kind of where to go for additional questions and information. So look for that to come out very soon. There is something that is on the page that you are on right now that I wanted to talk about, Heike. So luckily, you can read my mind. If you can just expand the testing information.
So give me just a second. That is actually a static image, so I will share the appropriate screen. One moment.
Okay. So while Heike is doing that, I did want to say that, you know, another Captain Obvious statement here. You may have seen in the news that President Biden put out information and is going to be requiring the vaccination for long-term care facilities to receive and facilities to receive Medicare and Medicaid funding. The requirement for CMS to develop the rule around that is not, the deadline is not until September. So there's a lot that we don't know that we will be finding out in the coming months as far as how does that apply to any of the settings that might be within our purview and within our world. So we will continue to keep you updated. But I think in the meantime, it's really important to access testing and do everything you can around that, especially from those that we've seen so far implement required vaccines. Not that this will happen with CMS, but I'm just giving an example, is that the entities are requiring a vaccination or weekly testing or biweekly testing as a condition of employment. So again, we don't know what the actual decision and rule from CMS will look like, but I do think regardless of that, it's more important than ever to do regular testing. We know it works, and Binax testing is available to all of our partners, and the information on how to use it, how to obtain it, is all on this page under testing information, and we really encourage you to do so. We do that here at our building. Everyone is tested once a week. We do it at our facilities more often, and that's just kind of depending on the current situation of if we have any positives or or what's going on in the local community surrounding that facility or state-operated program. So just really encourage you to utilize that resource and identify positives as early as possible to prevent infection of others and a spread or outbreak. And that's really all of the information that I had to share. So everybody gets to have 5 minutes back in their day, because I didn't see any other questions come up in the chat while I was talking about that. I hope everyone has a wonderful weekend, and I know lots of kiddos are going back to school next week, so good luck with that. All right, thank you.